You have missed your vacation, Melissa. I'm sure you could sell me something. Thank you very much for asking me to speak. It is a pleasure, because for us it's around 50 years when Dr. Alt started work in the Urella Society, and we first started to meet young children. The Urella Society ran schools. New South Wales had them. I think Queensland had them too, and they were one-stop shops. They were a fabulous model where you could go to school, your OT, your physio was there, and then they would arrange for medical appointments and even orthopaedic surgeon visiting. So it was really quite timely and really very interesting. So when I was asked what project I would like to do for my doctorate, I offered to, and I'll tell you more about why, I offered to undertake to meet the families and study some of the things about OI. And the things that I think worried people back in 1975 was, could we have a baby who might have the really severe form of OI? And so there was a lot of variability which totally wasn't understood. I wanted to just give you an idea of what I'm going to talk about. And I'm going to talk about the period from 1788 to 1977. That was a historic period, and there is a lot of history, and if you read in the OI literature, you know, people report a patient here or a family here. And then I want to talk about the new classification, and then I want to talk about what happened from soon after the year 2000, and confirming that there were many types of OI, and then address some of the future hopes for us in terms of transition to adult care and therapies. Yes, it is going. So there were many different names for OI, and that's the first confusing thing. And fragilitis osseum was an early name given to brittle bones, and osseum refers to the Latin word for bone, and well, fragility is an English word too. But Dr. Vrolik coined the term osteogenesis imperfecta, so in other words, imperfect osteobone genesis development, and it's the term that's actually preferred today. Just a couple of other words that you need to know, and so when you hear doctors talking, we talk in our other language, our medical language, and in this field there is a lot of Latin and Greek. So all the original classification was in Latin and Greek words. So we have a word, nosology, which simply means naming, and we've classified and reclassified. And what I was distributing to you is the latest classification, in other words, the latest ordering, and some of the nosology, but the naming is another thing itself. Back a century ago, they started using the word congenital, which means at birth, and tarda, which meant onset after birth. And then there were other names, and one name that I refer to is Dr. Ekman's name, 1788, doctoral thesis on osteogenesis imperfecta, a fragile bone family from Sweden. And the other thing I want to talk about is the whites of the eyes and this word sclera. So how did we get to start this project? Well, back in 1972, the short-statured people of Australia donated funds to the gentleman in the centre, who's Professor David Danks, to undertake a study with the assistance of Lucille Hutchinson, who was a social worker, to find all the people with genetic bone disorders in Victoria. And when they did this, they came up with two big groups of people: osteogenesis imperfecta, about half of all the people with any type of genetic bone disorder, and all the other genetic bone disorders. So you can see how prevalent osteogenesis imperfecta really was. But of course, we're talking about families who'd had a baby who'd passed on already as well as families who, extended families. And these were two of the committee members, and John Davidson, who was the president of Short Statured People of Australia, or was then called LPAA. So 1974 to 1980, so I've just got to keep turning to. So when we came to this writing up the research proposal in 1974, OI was thought to be a single disorder, and all forms, mild, moderate and severe, were thought to arise from just a single gene, and that single gene probably was a gene for what were called the collagens. And they just started extracting this substance from tissues, which is prevalent in bone and skin, ligaments, the eye, the tunic of the eye, and was called type 1 collagen. And they didn't even know there were other types of collagen. There are now, I think, 34 types of collagen. So that shows you how much our knowledge has gone ahead. And all forms were so common, as I said, they made up 50% of all the genetic bone disorders. And the situation with the children was very much like this. So if you had a fracture back, perhaps some of you will remember, you had a fracture, it meant that you were put into bed, you possibly ended up in traction or ended up in long leg plasters, plasters going up as far as the hips, hip spikers. And after a period of immobilisation in the orthopaedic ward, you were sent to a convalescent hospital, often one close to the sea, for a period. And there were long periods, therefore, of being away from school. So one of the first things we actually did, we noted that some of the people coming to see us actually had very blue scurry. Can we dim the backlights, or is that possible? Does anybody know if we can turn off the backlight? No, I can't see a switch. Oh, thank you, Art. Brilliant. Yes, we could leave it down. And so here you can see one of the young people, Leanne, came with me to an ink manufacturer called Colley and Sons. They did a lot of the printer's ink in those days, and they developed a very special ink. This ink is a mixture of different colours that comes up with this very blue whites of the eye. And in the back of, I'll put a few of them out, on the back of the brochure, which the Society actually funded, the second little booklet for medical practitioners, Colley actually gave us the formulation so that we were able to reproduce that ink colour and print it on the back of that booklet, and that was sent round to lots of GPs. And so with this ink chart, we started looking at the family's eyes and the children's eyes. Now, our study was assisted by a young honours student, Alison Sen, and in the end we saw around, we ascertained 180 people or children in Victoria with various types of brittle bone disorder. Now, we were very fortunate, we can't do this again, but in those days they kept a register of every child who died, and they all had formal reports. So we were able to go back to 1950, look at all the reports and work out what they were. And it's been very interesting that I've still, in recent times in the last year, had a family write to me about their brother or sister who'd passed on years ago back in that period, and tell them what the diagnosis was. So we've kept those records. So this squirrel feature turned out to be an important thing. And out of our study, there came to be a number of different patterns which we saw. A pattern of people with very blue sclery, which was probably the prevalent group at the time and easy to recognise, with a high frequency of hearing loss by the time they were in their 30s or 40s. And this became known as OI type 1. So these numbers were not developed by me. Professor Victor McCusick, who was the very distinguished geneticist of the day and has given his name to the big genetic database, wanted our various patterns numbered. And the other pattern we saw there was one where babies had a form where they had perinatal, means before birth, and they had fractures, many fractures at birth, continuous beating of the ribs from a fracture every few millimetres along the rib. And then there was another pattern where the children often had fractures before birth, but what was true is after birth their bones became bent very quickly, and their spine often developed into scoliosis. And then there was another pattern where there were families who were no different from the type 1 families, but they had normal sclerosis. They never had blue sclerosis, and they didn't tend to get as much hearing impairment. In fact, it was a much low frequency, and this became the international classification, and is still the classification that you'll usually be diagnosed with today. So there is another classification which we're going to talk about in a moment. So between 1980 and 2004, I came to Sydney, and one of the things we did was that we needed to let families know that we were establishing a clinic for people with OI and the OI Society, and we contributed to developing a multidisciplinary team, which is something I want to talk about, with occupational therapy, physiotherapy and rehabilitation. We wanted to work with the orthopaedic surgeons. There were quite a number of surgeons who looked after 1 or 2 patients, but we wanted to bring them together to talk about how we approach an integrated treatment program for kids with OI. And we developed bone densitometry, which I'll show you, and also a treatment with bisphosphonate therapy. So this scientific doctor, Dr. Christine Barlow-Stewart, who's gone on and developed the profession of genetic counselling. Christine joined me almost within months of returning to Sydney, and helped with a whole lot of matters. And as we previously mentioned, the society had already, by 1981, started to prepare a handbook for medical practitioners, and with the help of the pharmaceutical detailing, in other words, this is not a pharmaceutical company, but MEMS produces booklets on an annual and also long-term basis for medical and health practitioners, and they agreed to print this booklet and distribute it to all medical practitioners. Actually, when I read it, I think it's actually a fantastic little book, and I'm sorry, in a way, we didn't have computers in those days, we didn't have the internet, and it was never actually turned into a digital book, which is really quite a pity. I rewrote the booklet that the Society had, which is why I'm just credited with being the editor, and wrote all the new stuff about different types of OI in it. And then a bit later, by 1992, it was clearly out of date, and Christine Barlow-Stewart assisted, and we rewrote that with a whole lot of information about genetic counselling and what was happening. But we still didn't know very much more about causes, except that there were different patterns of inheritance, and we knew only about one type of, well, we knew by then of 3 types of collagen, but only one of them seemed to have anything to do with OI. So now I've got to do this. So here's the blue scale on the back of the yellow booklet, the 1992 booklet. A bit later, at the Children's Hospital at Westmead, we actually produced this little booklet, which is really quite an interesting booklet too, on bisphosphonate treatment and research programs for, and that was a booklet for parents. Oh dear, what have I done? Something bad. So sorry. By 2012, you can see that we had ascertained 530 people in New South Wales. This is just New South Wales with OI, and we had a lot of kids, a lot of people in transition between 16 and 25, and we tried to argue the case not only for services in children's hospitals but services in adult hospitals, and that's a continuing discussion. So one of the themes, and it really came out of our experience of working of Jenny working for the Urella Society, but also it was clear that the head of allied or physiotherapy at the Children's Hospital at Camperdown at the time was keen to integrate the work that the physios and OTs did with the work that clinicians, orthopaedic surgeons, rehabilitation specialists did. So, so our challenge was to bring together this team with sufficient committed hours to support service, and training is a very important important part of what we've been trying to do over the years. So Wendy Hawker organised Annette Biggs, who was an OT, and Kerry West, who was a physio, to support the service, and Jenny joined them soon after this was brought together by a grant at the time from Neville Rand, who was the Premier of New South Wales, who happened to visit and blessed this service with additional staffing. So it was the clinic service was called a connective tissue dysplasia service, and that was because the molecules that underlie the disorders which various children with various disorders had are connective tissues. They're and bone is a specialised connective tissue with a lot of calcium phosphate or apatite impregnated in it. And on your left is Wendy, who went on to become head of allied health and greatly supported over a long period. So for the children who clearly were affected and often hypermobile at birth, we instituted a program of demonstrating handling for all kids with OI, how to change nappies in slippery little babies and avoid fractures. But also we instituted a program for children who were particularly fragile, and you can see some of the things which our OT colleagues and physio colleagues came up with car seats that were padded and also reclined seating. And I'm not going to speak to you today about a very important subject called basilar impression, but we instituted a program when we realised that certain children were at high risk of pressure on the base of the spine, which became a lifelong challenge for them. But here's one of the mother with forward reclining her baby to try and take by resting baby on her chest to take some of the pressure off the spine. And this is this supported Fraser chair. We use this for other disorders as well, and also instruction on supporting the back during nappy change. And of course we were very fortunate when we moved to the hospital at Westmead that we had a hydrotherapy pool built into the hospital, so that from 1996 onwards we were able to offer hydrotherapy as an integrated part. Somebody may recognise themselves, but and this is a specialised chair that was promoted by the physios called the tumble form chair, which allows for the chair to be tilted at different angles. So we produced several versions of this, and this the second edition became an e-book, and it's on your website. It desperately needs to be rewritten, and there are various drafts of its rewriting, and what I've circulated is the classification part of it, which I couldn't quite do the other things before this meeting, which I can provide to the Society if they want to put it up. So the other thing that made a huge leap forward for kids with OI was adults. We could measure bone density in adults, but it hadn't been done in children. And so we started in 1987 and developed a new technique became available called dual X-ray absorbed geometry, dual energy X-ray absorbed geometry, and this turned out to be a fabulous technique where using two beams of X-rays, very low amount of amps in the beams of X-rays, but of different frequencies, produced an image and also a valid measurement of bone density. And we started with a lovely children's nurse, Kate Morley, who had a real gift with children, and she started off the collection of data. And then Julie Briody, who many of you know, who's still there, who has a master in biological measurement. Julie followed on from, and we recruited from your families 240 average kids without OI. They were used as the comparison. So we had about 10 boys and girls of every age up to 16, and all your measurements you were done on quite a few of the people here are compared with those 120 boys and 120 girls, siblings of different ages. So it was really fabulous. We can't measure babies under 3 accurately because they come in all shapes and sizes, but once we get to about 3, we have very valid data. And that's allowed us to introduce treatments, and this is Lunar Prodigy, but there's the Lunar Expert. The next generation is just absolutely space age, but going backwards, yeah. So, and here you can see this is a study of 121 children with OI type 1. And one of the things that's really interesting, as you notice, is that when kids with OI type 1 are little, they've bone density. So we measure bone density in standard deviation scores called Z scores, or Z scores. And if you notice, 0 is just average. 0 is average, plus 1 is one standard deviation above average, and minus 1 is 1 standard deviation below average, or plus or minus 2. Below minus 1.8 is roughly getting into what is called the osteopenic range, or 1.5 the osteopenic less bone range. But you can see what happens in young people with OI is that their bone density is falling away from average as they reach puberty. So one of the things that we're keen to do, of course, is to move that so that the young people maintain their bone density going off into puberty. And yes, the fracture frequency may drop off, but brittleness doesn't. So there is no World Health Organization definition for children, and we use fractures with minimum trauma and or bone pain, and bone density scores are less than minus 1.5, or a low bone mineral density standard deviation score less than minus 2.5. Not all children with OI do develop this less bone, not enough bone. The other thing, of course, is it was known for a long time that children with OI, particularly OI type 1, often had normal bone density when they broke their bones. And that had been known for a long time, and it's one of the big misconceptions, because kids with OI have brittle bones. They have brittle bones. They may develop this, osteoporosis, And osteoporosis is our big trouble the moment you go to bed for a week, or you put in spica for a week, or traction for a week, your bone density drops. So it's the problem for youth, it's a problem for elderly, but so there are two factors, brittle bones and osteoporosis adding to their brittleness. So between 1975 and 2005, there was a huge breakthrough, and that was the introduction of bisphosphonates into the therapy of OI. And I think the intuitive study was undertaken by a lady, Eva Astrom, from Sweden, from the Children's Hospital at the Karolinska Institute. So this is Eva on the left. She came to visit Craig Munns and I and brought all her team, her physios and OTs. They wanted to see what we were doing, which was really quite an honour to have this group from the Karolinska all come. And so Eva, like us, had sort of concerned about, wasn't there something we could do for the children? So by 1989, she had started using intravenous treatment, actually monthly, for children with OI to try and reverse their osteoporosis. Remember, bisphosphonates don't reverse brittle bones, they reverse osteoporosis. So of course the children we're interested in treating are those whose bone density has fallen below that magic minus 2.5 or minus 1.5. And so you can see that we've treated into the second hundreds, well over, I don't know, 180 or so children since we'd started with cyclic intravenous pamidronate, but a number of the people here are also in the oral trials. In other words, they took a medicine called risedronate or Actonel, and that also maintains their bone density and is effective in preventing, in children who are perhaps more mildly affected, prevented them developing osteoporosis. And this is really quite remarkable to have such a good result from this therapy. So in 2022, we hope most children with OI have had bisphosphonate modified OI, and this means that more children will have mild or moderately severe OI, and hopefully the severe form will become a level of severity only seen in the past. So in children, medical therapies for bone and other than the oral or intravenous bisphosphonates are still being trialled, and there are a number of other agents that are still being trialled. It's clear already from the trials there are downsides. There is a type of OI called OI type 6, and it has been somewhat refractory to bisphosphonates. And so the group from Cologne in Germany have used denosumab, but to consolidate denosumab treatment, in other words, to stabilise it after you get your improvement, you need to stabilise it with some other treatment agent, which usually means a bisphosphonate. So in adults, it's somewhat different. There are a number of approaches, and there's more evidence for precision therapies. In other words, knowing the type of OI a person has, prescribing a particular type of treatment for them. For example, there is an agent called teriparatide or Forteo, and that's most effective for people with OI type 1. And it is not as effective. In fact, it probably is no better than placebo for many other types of OI. Critical alert though, and that is there are adults, I'm sure there are adults here who haven't talked to their doctor about bisphosphonates, but adults who have never received a bisphosphonate need to know they may have a first dose reaction with severe flu-like illness, bone and muscle pain, if they had just given it as an adult and they've never had it as a child. What we don't know is whether children who had bisphosphonates as a child and are given bisphosphonates again as an adult when they start to develop osteoporosis. What we don't know is that whether they'll get the flu-like illness. Permidronate is washed out fairly quickly, but Zometa or zoledronate has a very long half-life, you know, measured in many, many years, and it may be protective, but we don't. That's one thing we don't know. So, the next era has been this, since the sequencing of the human genome around the year 2000, has been this sort of sequential discovery of types of new types of OI. In other words, new patterns of variations in genes that result in brittle bone disorders. And so in 2022, I've passed around to you. We could probably put the lights up if we could. Can somebody reach over and turn the light up? Oh, thank you, whoever did that. Good. So you can see I have kept the broad Sillence organisation, but for some groups, such as very severe OI type 3, there's multiple causes. I mean, there's at least 18 different genetic causes. Yes, it's more common to have a change in a collagen gene, but for example, if you're from Southern Africa, it's more common to actually have the change in FKBP10 gene, and that's the majority cause of OI in the population in Southern Africa. So it does depend on the population, and there are variations, you know, in different populations. So you can see I've said there are three patterns of classic OI type 1, of OI type 2, the perinatal form. There are 6 different genetic causes. The types with that in the past led to progressive deformity, there are 19 different genetic causes. And this common variable type, which can be really quite mild, has at least 10 different causes. Normally the sclerae are usually normal, or they might be a bit blue when they're kids. And then OI type 5 with dislocated elbows, just one cause, and one with this distinctive bone pathology, which is called OI type 6. So in addition, there are 21 other named syndromes. So with or other familial bone fragility syndromes. So this is turning out. That's about turning out to turning out to be quite complicated for geneticists. And some of the disorders have identical features to the numbered types early in life. So you can't always tell in little children what type they're going to have unless you do genetic testing. So today we recognise 3 patterns of inheritance, which was in my doctorate, but not actually discussed back in the early days, and that there is a sex-linked type, and this sex-link means inherited through mothers. Sons are affected, so 2 sisters might have affected children, but not have a parent OI themselves, although I'll come to the sex-linked type. So there are 6 groups of disorders. We've recognised that OI type 6, which is due to mutations in a gene called SERPINF1, has a very specific pattern, a different pathology from the other disorders. There are at least 33 genes which are implicated in different types of OI, and next year there'll be more. There are more in the pipeline. So what I've given you is just the beginning, because I can see from the international conference that there were several more genes that are being discussed. They need to be found in several families before they're reported. at 22 number types and 21 rare syndromic types. So, I'm going backwards, sorry. So, just to remind you again, so it appeared clear the eureka moment was some families had very blue sclerae and other families didn't. It does mean something. It's not due to thinness of the sclerae in people with blue sclerae, it's due to the accumulation of molecules in the eye that cause light scattering, so it's like the blue sky due to the dust in the upper atmosphere of the planet. Both these girls have OI, but one has blue sclerae and the other one doesn't. Just in terms of, I'm just going to talk a little about OI type 1. How am I going for time? Do you know?
You've got 20 minutes.
Oh, okay, all right. Well, just very quickly, I don't want to go through all the 22 syndromes, but OI type 1 is important because it's of course a familial pattern, it's dominantly inherited. People still can get, while it's said to be non-deforming, which is what the scientists like to say, it can still cause front to back curvature of the spine. Hearing impairment's very common in OI type 1, and the other features that we've been working with are joint hypermobility and sprains and easy bruising. There is a distinct subgroup of people who also have opalescent dentine, and I will put out later the ADA, the Dental Association's handout on bisphosphonates and ensuring that you have good dental care, particularly if there's a consideration about starting on bisphosphonates. These three people at one of our conferences all have OI type 1. This and shows you the sort of variability to an adult with quite average stature, sorry to go back, average stature. Some people have very special variations genetically. And of course, easy bruising and sprains are, an important feature. And in common variable OI with normal sclerae, there are multiple forms. As I've said, the sclerae are normal or normal to white in adult life. They may be bluish when they're young. There is a wide fracture variability. There are people who are quite markedly affected and variability in families. So, and there's a low frequency of bruising and a low frequency of hearing impairment. And, it was interesting at the Brisbane conference, there were a number of families, with OI type 4. And actually one of our largest Indigenous families has 80 affected people in the family. And, I've met them in different places with different names, but they are the one family, they have the one ancestor. And these are the different causes. They don't have blue sclerae. As you can see, some are dominantly inherited from a parental generation, others are recessively inherited, and there are 2 sex-linked forms. So sex-linked forms of OI had been recognised, but geneticists sit down and draw family trees, and when in considering X-linked inheritance, one needs to sit down and collect the family tree, and if it appears that the disorder is transmitted through mothers, then and boys are affected, girls can be affected, and in fact there are a few markedly affected girls. And we don't understand all the variation in X-linked families, but on the whole, the pattern becomes clear. Sclerae are normal, and these And the other thing I wanted to just comment about is there is a disorder called osteoporosis of pregnancy, and carrier mothers are more prone, of course, to develop this osteoporosis during their pregnancy. Don't worry, you have a dominantly inherited form. You're looking worried. And then there's OI type 5, which again has been known for a long time. Dr. Battle described this back in 1908, in fact, and then it was extensively described by Dr. Bors, who was from Adelaide, an orthopaedic surgeon who studied all the people with OI in the orthopaedic clinic at Oxford when he was a fellow there. But it was not till 2002 that Dr. Gloria actually published this with the name OI type 5, and then some years later found to have this unique type of variation, and it is a single variation in people who have OI type 5. You see this magical, the little, so this says that within the genome at -14, that is 14 base pairs upstream from where the gene usually starts being read, there is a change of a cytosine to a thymine, and that leads to this particular disorder. So that IFITM5. There is a very rare other disorder that results from variations in that particular gene. So Tim on the right just could never extend or rotate his elbows, and you can see. And this young person, she had bent elbows prior to being born, and actually the obstetrician contacted me. He said, look, this was really unusual. He had this little girl who had a bent elbow, and then we looked at her x-rays and it was clear she also had OI. And what they have is, as the years go by, the people with OI type 5, they developed ossification. They develop bone between paired bones. In other words, it's the radius and ulna. So you can see bone growing, a bone being formed along the inner surface of the bone here. And the same between the leg bones, the tibia and fibula, you can see extra bone. And that fuses the bones together, so they're not as mobile in terms of rotation. And that leads to the dislocation. Oh, sorry. Our family allowed us to show this picture to show the variability within the family, and some of you know this young man who's actually an orthopaedic surgeon in the United States. So the confusion is numbers, and so there is the Sillence numbers, and that's 1 to 6, and they're all grouped or classified together. And then there's the continuous numbers 1 to 22, and there'll be more of those because they're numbered after the individual genes. But the first 6, of course, are just the Sillence numbers, but changes in collagens can lead to any of the first 4 types. So because of the different types of variations within collagens could lead to very severe bone disease, or in fact lead to quite fairly inapparent. So originally the numbers were just numbered in the order I described them, and that was the easiest thing. But later on, type 5 and this year type 6 were added. People mistakenly attributed them to severity, but never was a number attributed to severity. And Dr. Van Dyke and I actually had published this in 2014, and with all the showing what we define as what is mild, what is moderate, what is severe, what is extremely severe. And if you want, I can send you that So mild doesn't mean type 1 and moderate doesn't mean type 4 and severe doesn't mean type 3. That was a couple of scientists in the laboratory who wanted a simple word to explain this, but you have to see to understand what people with OI have. So among those other syndromes, there are syndromes with joint contractures. In other words, people who have tight joints. There are people with donut changes in the skull, and when you look at the X-ray, they look like donuts in their skull. There's nothing abnormal about it. They have a hard skull. But it's a very special disorder, and it's been described for, again, a long time. There are people with OI and eye involvement. In other words, they have either cataracts or more severe eye involvement. And there's also some severe forms, a recessive form with brain involvement. And then there are these familial osteoporosis syndromes in boys due to PLS3 diagnoses. And I think they're neglected. I think that, you know, they just have they start off playing, you know, rugby, and they have a few more fractures. They get withdrawn from rugby. Having said that, there have been reports of some little girls with this and a bit more severely affected. So I think we still have a lot to learn about sex-linked familial osteoporosis syndromes. So where to now? I think the challenge for us is understanding the many new types of OI and the continuing research. And looking at the program for the international meeting a month ago, which was held in Sheffield, a lot of the research is to do with mouse and zebrafish studies, and like I did talk about that in the Victoria meeting, how they study this little fish and its skeleton. The community studies are concerned about sleep disordered breathing and also recognising that there are other features to OI that mean that with ageing, you know, people should have heart checks as well as screening for sleep disordered breathing. So one of the things to be really clear about is Australian centres pioneered sleep studies and studies into sleep disordered breathing, and so that's where we have CPAP Australia. CPAP Australia is Australian owned, you know, it's bred in Australia. We discovered, you know, that you could use this simple positive pressure to, you know, correct or prevent this. And when we were young paediatricians, little kids who had sleep disordered breathing were in dire straits. I mean, because they could stop breathing. So there are several forms. There's continuous positive airway pressure, CPAP, and BiPAP, which is biphasic positive airway pressure for more complex needs. Just to remind us that a major bit of this is these disorders are genetic, and so genetic counselling is very valuable, and taking that family tree often does turn up things that are really important to know about, and not everything we know about OA is written yet, so there are still things to discover. And please, wherever you are in your life phase, please come and hear Associate Professor Christy Jones tomorrow morning, because she's going to talk to us about the latest with IVF and pre-implantation genetic diagnosis, and you're going to hear from perhaps Australia's expert geneticist in this field. She's a geneticist who's made a special career out of this, and she's a really wonderful speaker. So thinking about future generations, very important to hear Christy. So just about the society. So I'll read from the history which Lynn and the committee actually wrote. So early in 1975, when her daughter Julie was 12 months old, Betty Stone Street met Donna Reagan, her daughter Joanne, and 2 other OI children at the Old Children's Hospital. It was the first opportunity Betty had of meeting other parents of OI children, and to talk to them about common problems. Jean Gallagher, in the meantime, whose daughter Fiona had OI, was put in touch with Betty and Donna, and this small group of OI families initiated the inaugural meeting, including other interested families, and goes on, says lots of nice things. So Mr. McAuliffe, Michael McAuliffe was the first president and Pat Salmon the secretary, and that's where I joined you, or you joined your mum. So, yeah. So my first patient as a sort of a young doctor was Christmas 1974 when I met Quentin Kenahan. It's a roller coaster. Quentin sadly passed on.
Can I just let people know that in 2018, Quentin died at age 43.
Yes, I know. Yes, so I was saying he passed on. So yeah. Alison and I worked. Alison Sen worked with me for that first year. She was really wonderful. She certainly interviewed lots of the families with where there were multi-generation families. And OI Foundation Victoria was formed, as well as the Society in New South Wales. And I do remember meeting the societies, both societies, but by then was sort of headed overseas. OI Society, well, really OI Australia was represented you at the inaugural meeting of the OI Federation of Europe, and we became an affiliated society, but a number of our members, and certainly the committee, had been involved with the OI Foundation in the United States, and also the Brittle Bone Society of the UK. So one of the things that OIFA is very important, because what OIFA has done is it has supported quite a few of the conferences on quality of life, and they're ongoing, and we understand a lot of don't understand a lot of things. That was the inaugural committee. I happened to be there in 1993, so represented you. So congratulations on your 45th year, and thank you to all the presidents, secretaries, and committee members. And yeah.
So much, David. We super appreciate the history lesson and all the advancements that you've made and continue to make in the OI world, and we really, really appreciate that, and thank you. Now, obviously, this has been a lot of information, and obviously bisphosphonates and things like that have been ongoing, advancements for us moving forward. So how do we, as OI people, go back to our GP, and how do we implement what's actually happening with the current research, and how do we push for that with our GP to say, oi, we need this?
Yes, I think certainly as far as children are concerned, I think lots of paediatricians are aware. So GPs refer to paediatricians when they're concerned with a child with OI. I think GPs are aware far more on the adult end of it, and they have ready access to bisphosphonates. There are two things about bisphosphonates which are called caution. One is, of course, overdosing and ending up with aseptic necrosis of the jaw. In other words, a non-healing tooth extraction. So, and the other one, of course, is first dose reactions, which are really worrying. And I've had people completely out of the blue call me on Sunday night and say I'm dying. And I said, well, what happened? And they said, oh, I had OI. I was given this medicine, given injection of a bisphosphonate, because it's a terrifying illness. Every previous fracture aches, even fractures you've forgotten you've had, if you're given bisphosphonates as an adult and you're naive.
You're really selling it.
Something that should be probably mentioned about bisphosphonates as well is that if you are planning a family, that's often, it'll probably be touched on tomorrow, but you shouldn't have them for a number of years prior to.
That's the usual teaching, yes.
Yeah. In case you didn't hear that, the recommendation in general is that you don't have bisphosphonates before having a family. So all the ladies out there. Okay, and in terms of where do you see us being able to advance to in the next 50 years with OI?
Yeah, well, I don't see I think MEMS did a wonderful thing. Lots of GPs got those booklets. I have some copies, I'll put it out and somebody can just look through. I don't know, I mean, maybe we could just scan the previous booklets and put them up on the website for doctors. They're actually still quite relevant. So that might help. GPs have so much to think about and so much to do and so much medicine to deal with today. I'm boggled by what GPs have to know.
Yeah. Was there any other really quick questions to Lena?
Are we anywhere in the future near if we found genes, possibly if someone wanted to have a baby, removing that gene?
We're discussing that tomorrow morning.
Are we?
Yeah, yeah.
Yeah, no, I think you should ask Christy just that. I mean,
what's your thoughts on Evenity and OI?
so Evenity is Ramaswamy. Yeah. Both it has the same disadvantages as teriparatide. In other words, limited period you can take it. I think these probably both medicines. That's what I call this. Is now the next subject called precision medicine. Remember, I am now retired. So precision is knowing about the type of OI you have and what might, specifically help. Very clear study showing teriparatide doesn't work very well in anything else in OI type 1 when it can really rescue a bad situation, except it is injections for a year or 18 months, daily injections. And Evenity, it's a trial going on anyway, Ramaswamy. There are several people. There's a trial in children. It again is limited to taking a certain period. Like denosumab, you need to consolidate because it's like weight loss, you lose it, and then within a year you've gained it again if you stop dieting. So, yeah. So what I'm saying is that, your osteoporosis can return and fall off, fairly quickly.
Okay, we might leave it for there. It is actually morning tea time. So again, thank you so much, David. We super appreciate it. Round of applause.